introduction and then we can get going. So thanks everyone for joining us as we kick off or get back to grand rounds this year, 2021. We're really excited to have this talk on cancer rehabilitation from Dr. Megan Nelson. So as many of you know, Dr. Nelson completed her PM&R residency here at CU back in 2011, and then completed a fellowship in cancer rehabilitation at MD Anderson in 2012. She then moved back to her home state of Kentucky and has been growing her cancer rehab practice at University of Louisville ever since, where she is now an associate professor and medical director of cancer rehabilitation. She has become more and more involved with the Brown Cancer Center at U of L. She has been their cancer liaison physician for the Commission on Cancer Committee since 2017, and also recently was named Medical Director of Oncology Wellness for the Brown Cancer Center. She enjoys helping cancer patients at any point through their journeys. All right, I'll let you take it away. Thank you.
Thanks, Vera. Wish I could see you all. I can't believe it's been 10 years since I graduated from residency this year. So thank you for having me back. And thank you for allowing me to bring in the new year. Little did I know when I put this little picture at the bottom of the screen, 2021 loading, like how much would already transpire in just a few short 6 days of 2021, but obviously lots more to come, and I'm excited to see where 2021 brings us. So cancer rehab, let's see here. There we go. No financial disclosures, and just an overview, really three main questions I want to talk about and answer today. One is just who is a cancer survivor, defining that. Why is cancer rehab important? And the third one, where we'll spend the bulk of our time, is just how can a physiatrist help cancer patients? So cancer survivor, the true definition is a person from the time of their diagnosis through the course of their life. So it's not just living beyond cancer. Cancer survivorship truly is living with, through, and beyond cancer. So in my mind, cancer rehab is a critical component of cancer survivorship, as cancer rehab helps these cancer patients with, through, and beyond cancer. So just a little question to start with. In only five short years, in 2026, how big will the U.S. cancer survivor population be? Will it be 18 million, 20, 33, or 50 million? Well, the answer is B. Currently, there's about 17 million cancer survivors in the United States. And this next slide shows a nice visual of how the number of cancer survivors has really increased over the past several decades. The different colors in this image is the number of years post-diagnosis that the patients live. So as you can see, just starting with the orange color, less than 1 year of patients living past cancer diagnosis. That bar has increased some over time, but not as much as the other colors, meaning patients are living longer and longer post-cancer treatment. If you go up all the way to the blue bar, that's cancer patients that are living 15 plus years post-diagnosis. So this is kudos to all the oncology treatments that have grown and evolved and proven to be successful for our cancer patients. So this is a sobering stat to start with. 1 out of 2 men and 1 out of every 3 women will develop cancer in their lifetime. This isn't like the basal cell carcinomas or the squamous cell carcinomas of the skin. This is the melanomas and all the other major cancers. So that can be quite sobering. The next stat is enlightening in the sense that 2/3 of all those cancer patients, though, will survive greater than 5 years. So cancer truly has become more of a chronic disease. And what we in the rehab world see are a lot of the long-term and late effects. In a study on a lot of cancer survivors, 90,000 cancer survivors, showed that the leading cause of distress for cancer patients is actually the level of their disability. It's even more stressful than just getting the call that you have cancer itself. So looking at your all state of Colorado, in 2020, this says estimated new cases, but essentially all of 2020 hasn't fully been counted yet, but estimated new cases in 2020 is about 27,000, and I haven't seen stats on what's the estimated new cases for 2021. But estimated deaths, and that's of all cancer patients at that time during the year, is 8,000. So about 240,000 Coloradans are alive with either active cancer or had a history of cancer. So about 4% of your all's population have had cancer in their lifetime. And since 2004, cancer has been the leading cause of death. I was trying to look up to see where COVID stood for you guys, and it definitely has hit the top 3 causes of death in 2020 for the United States. So I'm sure it's up there for you guys too, unfortunately. But of course, coronavirus has not stopped cancer. So what kind of cancers in Colorado do you all see? Breast cancer is one of the most predominant cancers across the U.S., and that's reflective in Colorado numbers as well. And then prostate cancer is your number 2 new cases in 2020. And those 2 cancers tend to have the highest number of long-term survivors too. So in your experience with rehab, you will definitely obviously be coming across breast cancer and prostate cancers and all of these other cancers too at some point. So why is cancer rehab so important? One big reason is because their functional status of cancer patients directly affects treatment decisions. So if a patient is very frail, cachectic, not doing well with functioning on a day-to-day basis, their decisions on whether they treat the patient or not are directly affected. They may not provide that patient with the chemo that could help improve their survival. We know that the performance status, if it's improved, the patient's treatment completion rates are improved. Thus, it reduces their disease progression and thus reduces their death from their cancer as well. So performance status and function is directly tied to function or to mortality actually. So that's what the next line shows, is there is an inverse association between physical activity and mortality. And as we all know in the rehab world, function definitely affects quality of life for patients. So 1960s is really when cancer rehab started burgeoning. What's really cool about this slide is seeing that there are 9 fellowship programs now in the country. When I graduated 10 years ago, there were only 2, MD Anderson and Memorial Sloan Kettering. And now we have grown, and it's continuing to evolve and grow and grow and grow. So that's very exciting. There are 4 phases of cancer rehab that are defined. The first phase is prehabilitation. That's growing and evolving over time too, with a lot more research showing the benefits of intervening early with patients' functional status even before they receive treatment for their new diagnosis. Of course, that's not always amenable. For example, like an acute myeloid leukemia who shows up at the ER with white count of super high, they start treatment immediately and don't have the opportunity to prehab. But there's a lot of other diagnoses that patients have the diagnosis and then have time before the treatment starts. That's a wonderful time to intervene and hopefully improve outcomes. And then you have restorative and supportive rehab, which we are all familiar with just every rehab population. Rehab is somewhat unique to cancer rehab, assisting patients with a terminal diagnosis that you may see the cancer advance in advance, which also correlates with functional decline, and how can you assist them with as best quality of life as you can during palliative rehab. So this is just a visual reiterating that rehab truly is multidisciplinary. What's cool about cancer rehab and what's cool about oncology is they are also very adept at multidisciplinary care. They have so many different providers helping cancer patients get through their treatment phase. So this next slide is interesting because we have cancer patients that have a lot of different providers assisting them through their journey. So this study was done by Dr. Andrea Chaville, who is a cancer rehab physician and researcher up at Mayo Clinic in Rochester. She did a study asking patients to self-report how many functional issues they have. They also self-reported any symptom signs that are typically asked about in an oncology setting. For example, how's your weight, any weight loss, weight gain, nausea, fatigue, pain, self-report those signs and symptoms, but also self-report how many patients are having difficulties with their mobility, their ADLs, their speech, their cognition. 65% of those patients in an outpatient setting, and again, this is a lot of different cancer diagnoses, not just breast, but 65% of them reported at least one functional need, one functional deficit. And this number of 65% has been kind of reiterated in several other research articles as well. What's cool about this study, though, is they went on to do a chart review 6 months after the patient self-reported to say, well, how many of these functional needs got addressed in the chart and how many signs and symptoms that were also reported in the lighter colored bars were also addressed. And functional issues, less than 10% of them were addressed within the chart. And as you can see, the lighter color bars, signs and symptoms were more commonly addressed. That's because the weight is usually documented in the chart, pain is documented in the chart, and those are other issues that oncology providers are typically asking about. The other issue too, though, with this low number of functional deficits being addressed is that patients walk into an oncology office and they want to know what their recent scan was. They want to know when is the next treatment going to begin. There are so many high level questions that are heavy on their heart that they want to know first and foremost, that they may table their functional deficits and not bring them to light to the providers as well. So there are a lot of different impairments, rehab needs in the cancer population, and I'm not going to go through a laundry list of them tonight. And I'm not going to go through the laundry list of all the different types of cancers that are out there and all the different types of rehab needs within those types of cancers, but I am going to hone in on some very common rehab needs in the cancer population, and hopefully show you how you as a physiatrist can help these patients. We as physiatrists are really good about obviously identifying functional issues, but also taking a step further and asking more questions about what is contributing to that functional deficit. And usually it's multifactorial. It's not just one issue causing a functional deficit. And what's wonderful about us is we take the time to ask all those questions and dig deep. Obviously, we utilize the therapy referrals. We have medication toolbox in our kit and procedures, and we'll talk about several of those. So shoulder and chest wall pain in patients with breast cancer is fairly common. And there is a differential diagnosis to it, but one that usually pops to the top when talking about breast cancer patients is post-mastectomy pain syndrome. So what really is post-mastectomy pain syndrome? Well, it is a misnomer to begin with, because you don't have to have had just a mastectomy to have this pain syndrome. Even if you've had a lumpectomy, you can develop this pain syndrome. The classic symptoms, if you look it up or Google it, is pain and tingling that's in the axial region, also the medial side of the upper arm, the breast, and the lateral chest wall. That correlates with the nerve intercostobrachial nerve. And that nerve is susceptible to injury during breast surgeries for breast cancer. So in the red down here, intercostobrachial neuralgia, you can find in up to 60% of breast cancer patients. And this nerve is just a cutaneous branch off the second and third intercostal nerves. So obviously the nerve injury translates into kind of a neuropathic pain symptoms that you'll hear: the pain, the burning, the shooting, sometimes itching. But what this common definition doesn't include is the myofascial pain that is commonly involved in post-mastectomy pain syndrome as well. And that's where I think rehab physicians do a great job of doing a physical exam to identify myofascial pain and going beyond just the neuropathic pain component. So shoulder pain in breast cancer patients is fairly common too. About 60% experience some sort of shoulder issue. And they also have a high propensity of having reduced strength in the upper body. You will find a higher rate, though, if a patient has mastectomy versus a breast-conserving surgery like lumpectomy. And you may find a higher rate of shoulder pain in someone who's had very extensive lymph node resection versus like a sentinel lymph node biopsy. Patients who have higher level of post-surgical pain, they tend to get into a protective posture, meaning like protracting the shoulders and protecting the surgical wound, which translates then into this lower sentence here, shortening of that pec muscle, and also cramping the rotator cuff tendons in the subacromial space. So that puts them at risk for shoulder issues. Radiation can also cause some damage to, obviously the skin can get tight, but also the muscles can get tight. Scar tissue formation can obviously contribute to shoulder issues too down the line. So going back to kind of the differential diagnosis of shoulder and chest wall pain in someone with breast cancer, we talked about what post-mastectomy pain syndrome is, and then that myofascial pain component, you can see a lot of that within the pec muscle, the latissimus dorsi, and the serratus anterior. The latissimus dorsi can be kind of elevated during breast cancer surgery, and the fascia kind of removed up from the serratus anterior. And then the pec also is involved in the surgeries. And then radiation fibrosis syndrome, we'll talk a little bit more about that here soon, but obviously that can cause pain. The tightening in the fibrotic pathway in the muscles can definitely contribute to pain. Patients can then end up developing adhesive capsulitis because of limited range of motion in that shoulder post-op, and then for months and years later if they continue to limit that motion. We talked about the neuropathic pain. Axillary cording is interesting. As you can see in the picture, you can see really tight, kind of almost like guitar-like strings. It's theoretically caused by thrombosed lymphatic vessels in the axillary region, and it's really painful for women, especially if they try to reach up towards the ceiling. Those tight cords limit that range of motion. And if you feel it on exam, it can feel like really tight guitar strings as well, or almost like tight spaghetti noodles. These patients worry about stretching the arm too high, but that's actually what you want to do, is you want to encourage and work range of motion and work with physical therapy. And eventually actually some of those can pop, which is a frightening sound and sensation. They actually feel it and hear it when that occurs, but that suddenly releases that range of motion for the shoulder. And then just other things that can be in the differential for any shoulder pain. Upper brachial plexopathy due to radiation isn't too common, but that's another thing to think about with breast cancer patients. So some other interventions we can do for the shoulder and chest wall pain, obviously therapy, physical therapy and occupational therapy. And in studies it showed that the women who go through physical therapy and occupational therapy have improved upper extremity function and quality of life 3 to 6 months after the therapy, compared to those women who only get like handouts on exercises to do at home. There are some interventional procedures, obviously, if the pain isn't reduced by therapy or medications, such as intercostal nerve block. We talked about the intercostobrachial nerve, stellate ganglion block, paravertebral block. One other block that's gained some attention in the past few years for breast cancer patients is serratus plane block. There's been some case series of this. I do these with an ultrasound, and essentially you're able to see your needle go between here, the latissimus dorsi, and the serratus anterior, and that's mirrored over here. A is latissimus, B is serratus, and the needle goes right between, and you can put a fairly high volume of anesthetic and steroid into that space. The theory is that it helps block some of those cutaneous intercostal nerves. Some people wonder too if you're getting somewhat of a trigger point effect as well. So that's been really helpful for many patients. And that helps not just the lateral chest wall pain, because you do it on the mid-axillary line, but also some of the anterior breast chest pain. Another thing as rehab docs we treat a lot is spasticity. So actually radiation can create a form of spasticity. We're used to spasticity being an upper motor neuron side effect, and obviously radiation is impacting some peripheral nerves, and we see this spasticity in breast cancer patients as well as head and neck patients. The theory is that essentially spontaneous activity is created along the motor nerve and releases acetylcholine across that neuromuscular junction just due to these nerves that are irritated from radiation, and creates that sudden discharge causing the muscle spasms. So antispasmodics orally can help, and there are some patients I've found who have this spasticity to do quite well with just the oral meds, but there are some that it doesn't touch. So we've elevated to botulinum toxin. Over here on the right, a breast cancer patient who may have had radiation causing spasticity and or I shouldn't say spasticity totally, but spasms in that muscle. It may be irritated even more by a subpectoral breast implant, kind of stretching that already irritated muscle. When I do botulinum toxin injections, though, with a patient with an implant, I do use ultrasound to delineate that edge of the implant, because the last thing I want to do is make a plastic surgeon mad and poke a needle in the implant. So, but I found a lot of breast cancer patients have tremendous benefit from botulinum toxin in the pec muscle. Head and neck cancer patients can also develop this cervical dystonia. A lot of times the radiation is more unilateral and affects one side of their neck more than the other. And injecting into the sternocleidomastoid has been really helpful, because those spasms will occur just unpredictably, just like in cervical dystonia. But these patients fear driving, because what if that spasm occurs and they can't suddenly turn their head for safety to look who's right beside them or in their blind spot. And then many patients have been using botulinum toxin for trismus or orofacial dystonia from radiation. This is head and neck cancer population again. What they found, though, in the studies is that botulinum toxin for trismus hasn't really improved their ability to open. Oh, I'm just getting reverb if somebody wants to maybe mute. It doesn't improve their ability to open their oral aperture, but it does help reduce pain. So that's been reported, at least for trismus in this patient population. So what I do avoid, though, when using botulinum toxin in this head and neck cancer population is I avoid putting it into the cervical extensors, because their anterior muscles can become weak and kind of fibrosed and pull the neck down, and I don't want to weaken their cervical extensors. And I also want to think about their dysphagia risk, because they're already at a higher level of dysphagia risk from the head and neck cancer. This picture is of actually 2 Hodgkin lymphoma patients who had Hodgkin's years and years ago. But this dropped head syndrome, and that's literally what's called dropped head syndrome, is because of the cervical extensor weakness from the high dose radiation. And so I'm using that as I just talked about head and neck cancer patients, because the head and neck cancer patients can appear like this over time as well. One thing to help them with, just from a quality of life standpoint, is a lower profile cervical collar. And this is a Headmaster cervical collar. But something low profile has been really helpful for these patients with dropped head syndrome, because there's nothing really you can do surgically or anything, but this will help support their chin so they can actually look people in the eye. So here's a patient I thought it'd be interesting just to kind of throw a picture up. And this is a head and neck cancer patient, to see what your eyes are automatically drawn to. And for me, it's the neck. And as you are looking at this, you're probably noticing kind of atrophy of some skin and muscle. You kind of see the prominence of the SCM, it seems like, appearing. But skin that's definitely not as mobile and stiff. So this radiation fibrosis here can obviously contribute to neck pain, range of motion issues, and you can imagine some swallowing difficulties. So obviously rehab has a large role to play in this patient population. Another thing that you may look at too at this patient is the shoulder atrophy here. In head and neck cancer patients, if they've had surgery, neck dissection, for example, the cranial nerve 11 is at high risk of being injured. And so they'll commonly have atrophy in the upper trap. And that's why it's also important to take these patients' shirts off to look at the scapular mobility. One other thing to notice in this picture that sometimes is a little bit more subtle, and this is exactly why lymphedema I feel is underdiagnosed, is because it can be subtle. There's a little bit of extra fluid in this lady's cheek. And so from a lymphedema standpoint and from a rehab standpoint, we have a lot to offer, especially with our lymphedema therapists who are certified. We traditionally think of lymphedema as just upper extremity breast cancer patient, but the head and neck cancer patient population does struggle with lymphedema quite often. As you can see here, this guy has significant swelling in his submental region, as is this man who also had head and neck lymphedema. And walking by him, you may not even think he's a head and neck cancer patient, but after some lymphatic massage, he had his neck volume reduced significantly. And then you also can see lymphedema in the lower extremities. And you tend to see that in patients with, for example, melanoma or your sarcoma patient population, or your GYN cancer population or GU cancer populations. There's lots of different tools for lymphedema, and it's not just compression garments. There's a specialized massage that's important to learn for the patient to be able to eventually do at home. There's also a cute way to wrap these individuals for volume reduction, and these are not ACE bandages. This is a specialized type of bandage to reduce volume. There are nighttime garments, and then there are pneumatic compression pumps too for upper extremity, lower extremity, and even head and neck lymphedema. So lots of things we can help as rehab physicians and as cancer rehab team to help these patients. I'd be remiss if I did not include chemo-induced peripheral neuropathy in this talk. It's one of the most prevalent neurological complications of cancer treatment, and it's a dose-limiting effect, meaning that if patients develop peripheral neuropathy while on chemo, the oncologist may reduce the dose of the chemo to try to minimize the neurotoxicity. And then sometimes some chemo agents will be completely discontinued due to the severity of neuropathy. So another important point to make is that comorbidities can elevate the risk of the peripheral neuropathy as well. If they already have underlying diabetic neuropathy, it seems that the risk of worsening the neuropathy is very high. There's lots of different chemo agents that can cause peripheral neuropathy. These are probably your most common, and for boards, for example, these are going to be your most common ones that may be on exams. I kind of italicized vincristine because it seems like that one's commonly in questions or test questions, but your taxanes, your platinum agents, and your vinca alkaloids. 30 to 40% of breast cancer patients do develop chemo-induced peripheral neuropathy, and at different levels, and they tend to have the taxanes and the platinum agents. So how can we help with a chemo-induced peripheral neuropathy? Obviously, physical therapy definitely helps with balance impairment that is caused from the neuropathy. what is reported that the fall risk is 2 to 3 times greater for those with a history of neurotoxic chemo agents. So being attuned to that and monitoring for fall risk in these patients. Occupational therapy, obviously helping with hand dexterity and ADLs, just simply buttoning their shirts is difficult. Some medication options in a randomized controlled trial, an SNRI, the duloxetine was shown to decrease neuropathic pain significantly with a dosage starting at 30 milligrams for a week and then upping it to 60 milligrams. So that's an option. Of course, we also use other cheaper options like gabapentin as well. Venlafaxine, the bonus to that as an SNRI is that for breast cancer patients who are on hormonal agents that can cause menopausal stage, which thus creates hot flashes, venlafaxine seems to help a lot with the hot flashes as well as the neuropathy. So that's a nice dual benefit. But when you see patients with chemo-induced peripheral neuropathy, it's important not to forget what else could be contributing to neuropathy signs and symptoms. There's been so many patients that I've also diagnosed with overlying carpal tunnel syndrome. They have chemo-induced peripheral neuropathy, but they also have carpal tunnel syndrome. And for maybe months or years or however long it's been, they say, well, my hands are worse than my feet, but that's just because of the chemo. And then you do an exam and you're thinking in the history and you think, whoa, wait a second, I think this person has carpal tunnel syndrome, and you start working on the carpal tunnel syndrome and they're happy campers. Also thinking of obviously degenerative spine disease and not just always chalking everything up to the chemo's fault. So EMGs can definitely be helpful in these patients. So we talked a lot about different ways that physiatry can help with cancer patients. Some words of caution, things that we should be thinking about with these patients. One that commonly comes to mind is bone mets and being worried about how much rehab we can do with patients with bone mets. The most common cancers that have bone mets present are breast, lung, and prostate. And you can also remember it with the BLT with ketchup and pickles. So you also got kidney cancer and thyroid cancer, but breast, lung, and prostate are the 3 most common that may have bone mets. One of the most common symptoms that you'll see in a patient is pain, maybe pain in the shoulder, pain in the thigh, pain in the hip that may trigger you, or pain in the back that may trigger you to consider imaging. When patients, for example, come into the hospital setting with like newly diagnosed, say, metastatic breast cancer with spinal cord compression, and that's the way they present, they've never been diagnosed with cancer before, and they come with full-on spinal cord compression. A lot of times the CT chest and abdomen gets ordered to look for how much cancer is present in the patient. One thing, if we are considering inpatient rehab for this patient population with bone mets, I do request x-rays of the femurs and the humerus, just because if we're going towards like weight bearing, more weight bearing in rehab, I want to know, at least have a little bit better appreciation of where other mets may be and weight bearing bones. But some do's and don'ts when they are in rehab is it is okay to do active range of motion, but you let the patient limit that by pain. And if you need to, you use obviously DME to help minimize weight bearing through that extremity. It is okay to strengthen the surrounding muscles, and it is super important for us to educate on risks of fracture, but also risks of inactivity. It can be really scary to rehab somebody knowing they have bone mets, but the risk of inactivity is just as high as the risk of fracture. We don't truly know how much it takes to break a bone and cause a pathologic fracture, but you do want pain to be your guide. What you don't want to do in these patients is manual muscle testing of the involved limb. You don't want to do passive range of motion of the involved limb or active assisted range of motion, and you want to avoid resistive exercises in the involved limb. Now, if they have a bone met in the femur and you know they don't have it in the humerus, they can do upper extremity resistive exercises, but you don't want to do lower extremity. And if they have rib mets, you want to avoid, of course, chest percussion and vibration. it gets tricky with these patients if they have spinal cord compression and are paraplegic, and you need, say they do have a humeral met and you need their upper extremity to help with transfers, you kind of have to get into a conversation of risk versus benefits, or just use Hoyer lift, or figure out what's going to be the least risky maneuvers for those patients. But always documenting what your conversation is, and documenting or talking with the patient about those risks. Cytopenias are another concern for patients going through rehab. There was a study looking at patients, just 98 patients, but they did show that hemoglobin issues like low hemoglobin and low ANC and platelets at the time of admission were not associated with a transfer to acute care. So what level of platelets do you want to worry about certain rehab interventions? Definitely platelets less than 10, you want those patients getting transfusions. But actually, if you get to 20 and above, you can start to gradually introduce some levels of rehab. I won't go through all these different numbers, but and that'll be in the slides for you all to refer to. But greater than 50, you can do progressive exercises tolerated with the patients. With ANC, if the absolute neutrophil count is less than 500, you do want to be cautious with these patients. They can still do rehab, but know that the typical signs and symptoms of infection can be absent. So if they develop a fever, it is an emergency, and that's the type of patient, if you're on an inpatient rehab unit, you want to get them off for further evaluation of the fever. And the ANC tends to drop in a delayed fashion, not the day or the day after chemo. It may be up to a week or even longer sometimes after chemo. So we talked again about ways to be cautious and things that we can do. Another way we can help as physiatrists is talking about exercise. We prescribe a lot of medications, therapies, and interventions, but there's a lot of growing evidence on the importance of exercise in the cancer population. And we're kind of well equipped to helping with this conversation with patients. This is a really busy slide, and I put the link at the bottom of it so you can access it if you want to. I just discovered this as I actually was preparing for this lecture, and I love it, and I'm actually going to start using it in my clinics because it talks specifically about like how much aerobic and how much resistance exercise for cancer patients to do, and what that exercise can help. The top one I'll just bring your attention to is cancer-related fatigue. That is incredibly prevalent in the cancer population. And a lot of patients think, if I'm fatigued, I need to lay down and rest. And that's kind of what we're taught as we're growing up as kids. If you're tired, go lay down and rest. But when you have cancer, that fatigue can actually be mediated by exercise. So a balance of rest and exercise is important. So there's been tons of research to show that the number one best intervention for cancer-related fatigue is actually exercise. And it goes on to show all the different things we know that exercise can improve. It also talks about lymphedema. A lot of patients with lymphedema are scared to do exercise, don't know what's safe. And there is research, mostly in the breast cancer population so far, but showing that weight training, resistance training is helpful, and it does not exacerbate lymphedema. If anything, it actually helps improve lymphedema. But the number one, obviously, take-home message is the huge importance of avoiding inactivity despite having a cancer diagnosis. The other cool part about exercise and cancer, before cancer even occurs, there is strong evidence that physical activity lowers the risk of developing these 7 cancers. 10 years ago, we only knew that that physical exercise could reduce the risk of colon and breast. Now we know that 7 different cancers can be reduced by exercise, and there's moderate evidence that physical activity can reduce lung cancer risk. Well, now if you have cancer, it's helpful to know that exercise can reduce your mortality and your cancer recurrence. of these three types of cancer. Again, growing evidence, there's moderate evidence at this point, but there's growing evidence that breast, colon, and prostate cancer survivors should exercise because it can reduce their mortality and cancer recurrence. Obesity is a huge problem with cancer, and it's linked to so many different cancers. But the concern is once you do have cancers such as breast cancer, weight gain is linked to a worse survival. So exercise obviously translates into improvement, hopefully with obesity, mortality, and cancer recurrence. I'm going to skip that slide. So question is, how do cancer survivors do? Do they meet these exercise guidelines that are laid out for them? Because they should be exercising just as much as your patient population without cancer history. Well, we don't do so great. About 30 to 47% of cancer survivors meet the exercise guidelines. Why? A lot of studies have documented it's been a lack of recommendation from an oncology clinician. Yet 80% of these patients are interested in receiving their advice. So one thing we can do as physiatrists is help talk about exercise and the safe ways to exercise. Exercisesmedicine.org. This is a webpage. I put the link on here too. It's got a cool page you can print out that essentially you can do an exercise prescription. It walks you through. It walks you through the adult physical activity guidelines. And talks about what is aerobic activity, what is moderate, what is vigorous, and also talks about resistance training. So I bring that to your attention because also on that same website, you can get that exercise prescription form for all these different diagnoses too. So I thought that was really cool. But studies have shown that simply providing a written prescription is an effective means of motivating patients to be more physically active, sometimes by as much as 1 hour per week. So we have a powerful tool in our hand as rehab doctors to help patients exercise, to identify the rehab impairments that can be present in the cancer population, and hopefully help them successfully get through their treatment and hopefully achieve a better quality of life. So in Kentucky, in conclusion, it looks like I'm right on time, hopefully, but since I've been in Kentucky since 2012, so 8.5 years, I've been intimately involved more and more with Brown Cancer Center, which is the academic center. I have clinic here. For patients who are not Brown Cancer Center patients, I'm able to see them at my Fraser Rehab Clinic, which is nice to be able to tailor any kind of cancer patient in the community. I'm involved in the Cancer Survivorship Clinic, which I really enjoy. I'm involved in neuro-oncology multidisciplinary clinic once a week. I do go to the hospital for inpatient cancer rehab consults. And weekly, I meet with the rehab therapist on the bone marrow transplant unit. So that's where I spend my clinical time during the week. And my administrative duties now are medical director, as Vera mentioned, cancer liaison physician for Commission on Cancer Committee. And I'm just newly named medical director of oncology, restorative health, and wellness. So that's where I spend my time, and I see patients of all different diagnoses. And those are my references. And what else I enjoy doing in my free time is spending time with these people. So the person on the left, Lizzie, she was born 10 years ago while I was in Denver. So can't believe it's been 10 years. So I'm definitely open for questions, and thank you all so much for inviting me too.
Thank you so much. Really appreciate it. I think there was one question that came up in the chat from Dr. St. Farge. She asked, why not obtain a triple phase bone scan prior to rehab inpatient? And I think that was in reference to the patients with bone mets.
Okay. Good question. A lot of times that's probably insurance driven. Insurance may not approve that being on an inpatient scenario. They're costly scans. And and it's a good point too, because x-rays are limited on how many bone mets they can pick up. You have to have like 50% of the cortical you have to have 50% of the cortex eroded to actually pick up a bone met. But if the patient doesn't have pain in the extremity and the x-ray is fairly negative, I feel confident moving forward with rehab being pain limited. But if there is a higher concern, you do need to consider more like possibly CT scan or MRI if you're really suspicious.
Vera, can I ask a question?
Of course.
Megan, that was a fabulous presentation. Thank you so much. You know, you are on the leading edge of cancer rehab. I mean, it's really quite remarkable when you showed when you applied, there were 2 fellowships, now there are multiple fellowships. But it's still challenging, I think, for rehab physicians to get involved in cancer care. What advice do you have for either us as faculty trying to break in and get the oncologists to understand the benefits that we bring, or for our trainees, those who might be interested in cancer rehab? What advice do you have?
Yeah, several pieces of advice. I think I see the oncology providers as hungry for extra help for their patients, but they're also very protective of their patients, which I admire. They want to know who's seeing their patients and trust who's seeing their patients. So my recommendation is making sure you have face-to-face time, and it's going to be more than one time to really get to know them. And I think bringing to them maybe 1 or 2 diagnoses to begin with that you can really help them with, and explain in detail how you can help with those 1 or 2 things. And when you see that first referral, then picking up the phone and talking to them and explaining all that you can do. So then it reiterates the message, how you are directly able to help those patients. It's been really helpful for me to get clinic space in the cancer center as well. I think from one standpoint, the patients feel comfortable. They're used to coming to the cancer center. And if the physician who's seeing them is at the cancer center, they have an automatic kind of like sense of trust, and they don't worry about where they're parking and how to get there and all of the anxieties that certain new appointments can trigger. So I know that can be tricky because it's hard to find space, especially in academic world, to find a little nook and cranny to see patients within the cancer arena. But I think that's been really, really important for me growing my program.
Thanks, that's really helpful.
I had another question. I think fatigue is a diagnosis or a symptom that I often see in these patients. And I'm curious if there's anything you use, outside of just kind of talking through maybe some non-pharmacologic ways that they can address that. But how do you address fatigue in some of these survivors?
Yeah. I talk a lot about it in survivorship clinic because it seems to be that lingering symptom. It is important to make sure you're addressing any laboratory deficiencies too. If they're anemic from their treatment, I tend to sometimes catch hypothyroidism that hasn't been diagnosed, or low vitamin D levels. And so other things that can contribute to fatigue are important to catch. And then looking at cancer-related fatigue, as so many different things can cause it, not just the cancer treatment. So asking all the questions you would a typical fatigue person, such sleep, diet. So there's so many ways to intervene on fatigue if it's multifactorial. If it's just typically like cancer-related fatigue, they're exercising, they're doing everything they possibly can to help themselves. Sometimes you do lean on some of the other medications, such as methylphenidate, just to help them kind of get over the hump. Cancer-related fatigue does tend to improve. So just sometimes that knowledge that it may take months, it may linger for even up to 18 months post-treatment, but that can feel kind of like a big, breath of fresh air for the patients, just to know that the expectations. I wish I could see everybody.
I know.
When
Well,
next time I come out to Colorado, though, I will be calling you all and trying to connect.
If people can turn on their videos, Megan and I ahead of time were saying how interesting it is to be a presenter, especially in this, this is a national presentation, and not be able to see people who are actually in the audience. So people would humor us for even 2 minutes before we log off, just to be able to show your face and say hi.
Hello.
Oh, fabulous. Thank you, everyone.
Joyce. Hey, Joyce. I can't hear you, Joyce, but I see you.
I was messaging you. It's so good to see you. And that was so great.
Oh, there's Scott. Hey, Scott. I'm trying to scroll through. I'm sorry if I don't say your name.
Great.
Pam
Sorry,
Wilson's
in
on.
person. Well done.
Pam Wilson's on. She's an old timer.
Amy, I can't see you, but I see your name. I hope, well, it's so good to see some familiar faces and good to see some new faces too. And I think the pandemic is, oh, there's Sue. Hey, Sue. It's amazing that we can connect like this, like how awesome that is. And I see 2 twins on Scott's lap. Aww. Oh, they've gotten big too. Oh, there, nice, nice. I'm gonna take a quick picture if that's okay. All right. Say cheese, whoever's in the screen.
Cheese.
Yeah, this is an awesome way to connect, but hopefully I can get out there. And I still have my sister, my older sister in Boulder, so it's good reasons to still get out there. So I wish you all well.
Thanks, Megan. Take care.
We miss you, Megan. Do well.
Yeah, miss you guys.